Thank you very much for having me. I always love talking to audiences of patients and their families. And I've done that for a long, long time with the Hydrocephalus Association. I'm going to tell you more about them in just a second. I've also been telling everybody that we got here yesterday from Seattle, and your weather yesterday was just perfect. That was Seattle weather that we had, and today is like Seattle summer, almost even to the temperature. So you're making me feel at home. This is just a thing to tell you that I work for the Hydrocephalus Association on a volunteer basis. I'm on their board of directors, and we also have a panel of 25 physicians and nurse psychologists as our medical advisory board, and I co-chair that, and then we have some research funding. The Hydrocephalus Association is the largest group in the United States that's an advocacy group for patients and their families. And we have patients and families from newborns to 90-year-olds. So children with hydrocephalus, middle-aged adults with hydrocephalus, normal pressure hydrocephalus. And guess what? We're going to be in Texas. Our meeting is in June in Houston. And if you're looking for an opportunity to learn more about hydrocephalus and to have more talks like this one on normal pressure hydrocephalus, or to meet people from other parts of Texas or all around the country, it's a wonderful meeting. We have it every 2 years or so. And if you want to compare, if any of you have hydrocephalus or have a shunt, you can compare shunt stories with 6-year-olds who have shunts and so forth. So it's a real wonderful opportunity. And this is our first time in Texas. We're trying to move the conference around the country to make ourselves accessible to more people, because we recognize that travel can be a financial burden. So the title of the seminar was, well, what if it's not Alzheimer's disease or Parkinson's disease? And I'm grateful that all of you are here. And you might be concerned for yourself or a member of your family because of the symptoms of Parkinson's disease or Alzheimer's disease. And those three main sets of symptoms are dementia, or what we call cognitive impairment, and we'll tell you more about that in a second, difficulty with your walking and your balance, and difficulty with bladder control. And all of those symptoms also come together in this disorder that we call normal pressure hydrocephalus. And I'm going to look at these each in individual detail and then talk more about how do we move from this question of could it be hydrocephalus to actually making the diagnosis. So let me ask you this. When you hear the term dementia, what's the next thing that pops into your brain? Alzheimer's disease. And that's what most people think of. And we just make this mental shortcut. And when they think of Alzheimer's disease, many people think that it's incurable, memory loss, loss of personhood, sometimes nursing home. But in fact, Alzheimer's dementia is just one of many types of dementia. And they have multiple potential causes. Now, neurologists try very much to find disorders that are treatable. Not everybody who comes in to see us who looks like dementia actually has dementia, and that's part of our job. Of course, some people do, but there are some disorders such as low thyroid, deficiency of vitamin B12 or other vitamins. Sometimes if your blood pressure is treated a little bit too well, you get slow and you get groggy, and that can look like dementia. Normal pressure hydrocephalus is on the list, and actually medication side effects is on the list. Any of you on a list of, say, 10 or more medications? We see that a lot, and sometimes we find things that could be causing confusion or sedation and so forth. Now, there are also disorders that are not reversible, and these are things that everybody is afraid of. These are also areas where a lot of neuroscientists and neurologists are trying to understand, can we find a cure? Can we find a treatment for those disorders? And Alzheimer's disease is at the top of the list, and these are some others. This is called frontotemporal dementia. This is an area that Dr. Campbell is very interested in. Lewy body dementia. Vascular dementia is a disorder that happens to people who have chronically poorly controlled vascular risk factors like high blood pressure or diabetes, and so forth. And that's actually something that can be prevented with good control of those vital signs and so forth. And then here are some others. So when we actually think like neurologists about dementia, what we're looking for is something that's progressive. It's insidious. You go back and you think about it and you say, well, you know, my wife or my husband or my mom was okay 2 years ago. Somewhere over those last 2 years, something started to change. That's insidious. And it's not just, you know, honey, where did I put my eyeglasses? It's causing trouble with their ability to function with normal activities. And there are lots of things that the brain does besides memory that we measure in order to call it dementia. So sometimes it's how is our ability to use words or understand words? How is our ability to make judgments? How is our ability to find things in space? So all of those are features of thinking and memory that can be affected by dementia. And sometimes we also see change in a person's emotional control. Sometimes they're a little bit too friendly, which is a change in their personality. Or they start to make some suggestive language comments that would be very out of character for them. Or sometimes they start getting angry or very, very confused. And that can even be loss of control of emotions. All of us have the ability to sort of mostly keep ourselves from blurting out things that would be embarrassing. But if that control is lost, sometimes that's a sign of dementia. So there can be personality changes. And very rarely we'll see patients who have delusions or hallucinations as part of that. And so making mistakes with medications is one example. Now, you know what? I forgot my pills one day last week because I went in there on Tuesday morning and said, oops, there's Monday morning's pills. So we all do that from time to time. But when your family or your spouse realizes that there's a mismatch between when your refills are due and how many pills are left in your bottle, or you've accidentally taken something twice, or they realize there's a pattern, that's what we mean. It's a pattern of mistakes. And repeating questions or statements. Now, this is not the story that granddad tells every time about something at Thanksgiving dinner, not that kind of repeating stories. But they told you about something that happened yesterday, and then an hour later they say, let me tell you what happened yesterday, having forgotten that they just told you about that. Now, here's one that's a little tricky, which is impaired driving skills. And again, this is not the argument that spouses always have with each other about their driving skills, but driving a car is actually the most complicated task that the average human being performs. It really is, because you're in a big vehicle, you have to use your foot, you have to use your eyes and your ears and both your hands, and you have to know what's going on in front of you and behind you, and on both sides, and you have to know where you're going, and you have to know how to get there. So in fact, it's an incredibly complex task, and you're responsible not only for yourself, but for the safety of others. So dementia sometimes interferes with a person's ability to manage all of those tasks at the same time. So that can be a change. So not just, I never liked the way he drove, but there's a change in driving. And sometimes it's getting lost. It's like heading for Austin and ending up in Amarillo. That's getting lost, as opposed to making a wrong turn. So managing finances, getting behind on the bills, or not as organized as before, changing eating habits, and some of these other things. Okay, so it's not always recognized. It's not always recognized. And part of it is because it is insidious. It's very, very slow. And families sometimes come to a sudden realization that something is wrong when in hindsight it's been going on for a long time. And occasionally there's an event that causes that, like getting lost. Or there's often an assumption on the part of doctors and sometimes the public that, well, Mom's supposed to be like that. She's 70 years old. Isn't forgetfulness part of getting older? It's not a normal part of getting older. Or there's this assumption that it's all Alzheimer's disease, and well, we can't do anything about it, but that's not true. And sometimes patients don't get referred to appropriate specialists, or the specialists may not use all of the diagnostic techniques that are available. So there's a lot of things that conspire to result in inadequate recognition of that. So now let's talk about the next symptom. And gait and balance impairment is very prominent in Parkinson's disease. It's also something that we see in hydrocephalus, and there's a couple of terms that I want to define for you. So one is gait, and gait is just the medical term for how you walk. So, I walk back and forth, and that's my gait that you're seeing here, me going back and forth like that. And there's lots of different patterns to it, and we have ways of assessing that. So the next is balance. So for us to be able to stand up, if we didn't have a nervous system, we would have the balance of a broomstick. Boom, we'd go over just like that. So our muscles and our brain are controlling these reflexes that keep us upright. Those are called postural reflexes. And we need to stay upright not only when we're standing, but we need to stay upright when we're walking. So when we're walking, we're actually falling forward a little bit, but this foot is catching us. And sometimes the center of gravity gets too far in front of you and you end up chasing it. And the term that neurologists use for that is festination. And that gets us to locomotion. So that's not the dance, the locomotion, but it's just how we're walking. And our arms move back and forth, our feet move like that. So those are the parts of gait and balance. So most of us walk on two legs. And if you remember Shakespeare's The Seven Stages of Life, we're on 4 when we're crawling, when we're kids, and then when we get our walkers, we're on 6, because there's 4 legs to the walker and 2 legs that we have. But we are always, our body is assessing, where am I in space? How do I keep this balance? And a lot of the brain is necessary to do that properly, including the nervous system, the sensory system. So some people have very poor sensation in their feet from a problem called neuropathy. And there's this unconscious sense of what's the position of my body? How are my joints moving? And if you have neuropathy, you won't have that, and that gets in the way of your balance. Or motor coordination. When we want to walk across the room, there's actually a part of our brain that plans that. And then it hits the start button for the program that makes us walk to get there. And those can be disrupted in certain neurological disorders. And then you have the spinal cord that's involved. So it's really a lot of the brain and the body is involved. And oh, by the way, we need bones and joints to hold us up, and we need the muscles and so forth. So we're not necessarily talking about bad hips or bad knees. Yes, that will get in the way of the walking, but that's different from the brain's control of walking. Now, this is what I call a sign of difficulty walking. I think that's in England somewhere, elderly people like that. But it's actually a huge problem. 35% of adults over the age of 70 have some sort of trouble with their gait. And probably if you think about who are my neighbors and who am I living with, it might even be higher than that. But once you start to have abnormal gait, then your risk of injury goes up, risk of death goes up. That's risks from falling, among other things. And risk of institutionalization on this slide means ending up in an assisted care facility or a nursing home or someplace like that. And the risk of falling goes up a lot. And falling is a huge, huge risk as we get older. Our bones don't tolerate falls as well. There's even a risk of brain injury. So I sort of hinted at this a minute ago. What we're looking for as neurologists are the neurologic causes of gait impairment. So that could be from a stroke or spinal cord injury, muscle disease, Parkinson's disease, hydrocephalus, and then all these other things that also influence it. So if you have bad heart function, well, you're not going to have the ability to walk as far or as fast because your cardiovascular system won't let you do it. Or if you have lung disease, or if you have vascular disease. So we have to look at all of these things. And of course, sometimes people hit the jackpot and they've got both of those at the same time. So even this is something that's not always recognized. I'm sorry, was there a question over here? I'm sorry.
I don't know if the questions are going to be after or during. I apologize.
How should we handle this?
Usually we do after, but...
So write it down.
Okay.
You'll be number 1. All right, Campbell's going to help me keep track of who's number 1 and number 2. But even walking and balance isn't always recognized. And again, oh, well, granddad's supposed to be like that. He's 70 years old. But that's not true. You should have a normal walking and balance as you get older. So the onset of these changes is typically insidious, slow, when it's a neurologic disorder. Again, not falling and breaking your hip, but slow onset. And it's that event where finally, all of a sudden you're running so fast and you fall that makes you say, oh my gosh, I really wasn't walking so good last Christmas. And I often will ask families, do you remember what your mom or your dad was like last Christmas or the Christmas before? Because family events, they sometimes realize if they haven't been home for a while, boy, is there a big difference. So those are ways to cue into it. Again, this assumption that using a cane or a walker is part of normal aging, when it isn't, the assumption that nothing can be done and not getting referred to the appropriate specialists. So that brings us to urinary incontinence. And what we mean by that is loss of bladder control. And those symptoms might be very mild, a little bit of leakage, or uncontrollable wetting. It is more common as we get older. And I'm afraid that women have this twice as often as men as we get older. Now, we've kind of figured out that men and women have different plumbing. So the causes of their incontinence are going to be a little bit different, partly based on their plumbing. So one that's very common, more common in women, but actually sometimes seen in men is what we call stress incontinence. So this is where you lose a little bit of urine if you cough or you sneeze or you laugh really hard, and that's because the muscles of the floor of the pelvis have become weak. We often attribute this to having had children in the past. That it may not necessarily be the case all the time. The one that I pay attention to, the one that sort of comes out in hydrocephalus, is what we call urge incontinence or an overactive bladder. You get that sensation from your bladder, it's time to go, and you're trying to get to the toilet, and you can't keep your bladder from emptying before you get to the toilet. So that's what we mean by urge incontinence or overactive bladder. Now, men who have prostate enlargement may sometimes get that strong urge, and then they get to the toilet and they're waiting for something to happen because the prostate is making it hard for the bladder to flow. So we have to sort through all of those issues. And guess what? It's not always recognized as well. Well, you know, mom and dad are in their 70s. Isn't incontinence part of getting to be older and so forth? And part of my lesson to you today is, even though all of these symptoms are common as we get older, they're not normal as we get older. So if they're occurring, you always want to ask, why is that happening? Is there something that we can do for it? So these are, again, the symptoms that can come out with either Alzheimer's disease or Parkinson's disease, as we said in the title of the talk. But what if it's actually telling us that you might have a problem that's called normal pressure hydrocephalus? So let's talk about that. And this is a disorder that I've been evaluating and treating patients for over the last 30 years of my career. So it is a syndrome. A syndrome just means a collection of symptoms, typically of gait impairment as either the first symptom or the worst symptom, dementia, and incontinence. It affects people over the age of 60 years, and it's caused by impaired circulation of the spinal fluid within the brain. And I'm going to show you a picture of that in just a second. And what that causes on the brain scan, and this is one of the ways that doctors find it, is that the normal spinal fluid cavities inside the brain get larger than they ought to be for a person's age. So just as many things change as we get older, the size of the ventricles does change somewhat as we get older. So this is a diagram of the brain. It's actually a very old diagram from a textbook from the 1930s. And this represents the surface of the brain out here. And this curved structure here, and can you sort of see behind that? There's another one there. There's a pair of them like this. Those are the ventricles. They are within the center of the brain. And then they come together in the middle, in this space. That's called the third ventricle. That's how we got that name. Through this narrow channel here into the outside. So if we enlarge that, this is how it starts here. It's actually secreted on the inside. It's got to end up here. And this is the pathway that it takes. So that's the normal circulation pathway of the spinal fluid. But if these pathways are impaired, well, the fluid starts to back up. And the analogy that I use is like water backing up behind a dam. I heard you had a lot of rain here recently. So kind of like that. It's not a perfect analogy, but you kind of get the notion. If it can't get to where it's going, then it starts to back up, and that's what makes the ventricles get bigger. Now, this is actually not new. A neurosurgeon from Bogota, Colombia, Solomon Hakim, first described this in 1964 in his doctoral thesis. And I had the great pleasure of meeting Solomon about 20 years ago, and as he frequently did, he handed out a signed copy of his thesis to me. And if you ever wondered, well, where does the term normal pressure come from, is actually translated from the original Spanish there. He did this work when he was Bogota, and it was first published in the medical literature after he went up to Massachusetts General Hospital. So, okay, why is this a big deal? Well, we can treat it. That's why it's a big deal. When you think about all of these symptoms, and our goal is to try to help somebody get better, we can treat it. And in the right circumstances, it can be really significant. Really significant. But you gotta have surgery to treat it. And this is asking a neurosurgeon to implant an internal drainage system that's called a shunt. Now, sometimes people hear the word shunt, but their brain hears the word stent, but shunt is what it's called. And does require brain surgery, so we want to be sure that if we're going to send somebody to a neurosurgeon for brain surgery, we're doing it for the right reason. So, I've been doing this for a long time. People get sent to me for basically one or two or three reasons. The first is that somebody gets an MRI scan or a CT scan of them, and the radiologist or the neurologist looks at it and says, those ventricles are large. I wonder if you have hydrocephalus. So that's one way that people get sent to me. The other is they have those symptoms that we just talked about, and sometimes it's both. But I get any of those stories for patients who are sent to me. So let me show you what the MRI looks like. So over here, and I'm going to come over to this side just to help to point it out to you. This is normal on this side. So this is a view right down the middle, like this. So there's the bridge of the nose, there's the back of the head, that's the spinal cord there. That's actually the tongue inside the mouth there, if you ever wondered what that looks like. And that's the brain. And this is a very normal brain. This is the same brain in a cross-section like this. So that's actually the right side, the left side. And see that little comma-shaped thing here and here? Those are the spinal fluid cavities. Those are the ventricles. And this is what they should look like. Now look over here. Can you see the difference between those ventricles and that? So when we use the word hydrocephalus, which means water on the brain, that's what we're talking about. They're looking bigger. Now the thing about a chamber that contains fluid is if that fluid is accumulating, it not only expands this way and this way, but this way as well. So this structure is the top, and see how it got all stretched out like that? That's actually the roof of it. So these are the ways that I can look at a scan and tell that somebody might have hydrocephalus. There's that for you. But here's the problem with that. You can't diagnose hydrocephalus based just on the appearance of the scan alone. And that's because you can get enlargement of the ventricles through another process. So if you look at the scan of somebody who has Alzheimer's disease, what we call degenerative diseases, where over a long period of time there's loss of brain tissue, withering is a word that I often use to describe that, well, there's nothing else to take up that space but spinal fluid. And if the reason that the ventricles are large is that they have a degenerative process of the brain as opposed to trouble with the circulation of the spinal fluid, a shunt won't make a difference for them. So here's what this looks like. So look at all this space around the brain. On this one, the spinal fluid is white, the brain is dark, and that's the only one that's sort of the opposite of everything else. And here on this one, you see all that space around the brain. So that's loss of brain tissue, and the ventricles have also gotten large. There's less brain, only thing that can take up the space is spinal fluid. And here it is from the top, and you see all that space around the brain in here, as opposed to hydrocephalus. And you can see in hydrocephalus, the ventricles are big, but the surface of the brain looks pretty normal. Everybody see the difference between that? And you can use your hand to sort of illustrate the fact. If your fingers are together, that's kind of what that looks like on the normal brain over there. But if your fingers are apart, that's kind of what atrophy looks like. That's kind of a handy way to look at that. So let's now talk about the symptoms of hydrocephalus. And they typically develop over months or years. It's not sudden, and we usually say the symptoms should have been present for at least 6 months or so. Trouble with walking or balance is typically the first or the worst symptom, and it's not due to pain or weakness. Now, let me comment about the word weakness, because a lot of patients will come in and they'll say to me, "I'm weak, I can't walk." And I say, "Well, tell me what you mean by the word weak." "Well, I can't make my feet do what I want them to." But when I test their strength is normal. So they're using the word weak as a way of saying, I can't get going, I can't go to where I want. So for a neurologist, weakness means that my muscle that used to be able to lift 50 pounds can now only lift 5 pounds. And that's a little bit different from control of walking and balance. The next is they have impaired bladder control, that urgency and inability to get to the bathroom in time. And then they have a generalized slowing that should be of thinking and difficulty with multitasking. This is what we call executive functioning. Now, I'm not talking about the executive in the corner office, but those parts of our brain that you kind of hope that your youngsters develop before they graduate from college. Those are executive functions where they know how to think and have good judgment and to multitask and so forth. But here's the problem with the symptoms. You can't diagnose hydrocephalus based just on the symptoms alone. And that's because each of those 3 symptoms has a long, long list of potential causes. And so the challenge that I take on when I see somebody in clinic is to figure out, do they have this, that, and the other thing? Or do they have this, that, and the other thing plus hydrocephalus? And there's a lot of this, that, and the other thing that's out there. So in fact, here's a list of what this, that, and the other thing looks like. This is from a table I put together for a review article that I wrote for doctors. And here's some, you don't have to worry about reading this, but here's lists that can cause all 3 of the symptoms, or 2 of them, or that might influence one of the symptoms, or that might aggravate those symptoms. So a lot of what I'm doing as a neurologist is to go through this process of figuring out, is something else going on? Ultimately, what I hear from my patients and what I want is to make the right diagnosis and offer the right treatment. And if it's not hydrocephalus, that's okay. I still want to get the right diagnosis and the right treatment for them. So this is where we go into a little bit more detail. So there are some patterns of symptoms that can be very, very helpful. So occasionally somebody is sent to me for the question of hydrocephalus, and the only thing that's going on is dementia, this cognitive impairment that we talked about. And they don't have any trouble at all with their walking and their balance. And in that circumstance, hydrocephalus is very, very unlikely to be a cause. And so I'm going to take them through the evaluation of dementia first. Whether that might be Alzheimer's disease or something else, there's a number of things that we can do, neuropsychological testing and certain imaging. But somebody who has only dementia and no gait difficulty at all, I'm going to think about Alzheimer's disease or related disorders. Now the flip side of that is somebody who had dementia that developed early, say 2, 3, 4 years ago, and then gait impairment later in the late stages is also unlikely to have normal pressure hydrocephalus. In the late stages of many dementias, the late stages, many patients have impaired walking and balance. So if the story was really one of dementia and walking okay for a long, long time, and now in the late stages having trouble with walking, that's also unlikely to be hydrocephalus. And here's the flip side that I meant to refer to. Somebody who has no cognitive difficulty, but they have walking difficulty and they have trouble controlling their bladder, I'm going to think about their spine. So the spine is just a series of bones that gives us our backbone, but they surround and protect the spinal cord, and arthritis of the spine can cause narrowing of that spinal canal that can cause problems like that. So I'm always trying to be sure that we're looking at the right thing. Okay, so now let's imagine I've looked for those other things and ruled them out. What is my approach to the diagnosis of hydrocephalus? It's really these 5 steps. The first is we do a really detailed history and clinical evaluation in the clinic. If I do find something else that I should treat, we treat that first. We want to see, does that help or not? If it does, we might be done. We've pointed the person in another direction. If it doesn't, then we can come back to testing that's specific for hydrocephalus, and then eventually shunt surgery if they qualify for it, and then longitudinal or long-term follow-up for that. So let's talk about shunts, because all of this is ultimately going to the question of should I recommend a shunt for you? So let me ask this. Anybody in here have a shunt? Okay, at least one. So I know you'll probably want to ask some questions later on. So a shunt is a drainage system. So remember that excess spinal fluid. The purpose of a shunt is to drain the excess spinal fluid, but not all of it. Not all of it. And so this is a diagram. Here are the ventricles in purple up here. It's a little hard to see, but the shunt is here. And then all of this tubing, let me make these arrows come up, is under the skin, over the chest, and the very end of the tubing is down inside the abdominal cavity. So not in the stomach or in the intestines, but the cavity that holds them. And it just helps to drain some of the spinal fluid down here. And that process is what allows the brain to get better. Now, if you like fancy pictures, this is what we call a 3D CT scan, and that shows you where the shunt is on a person's head, and you can sort of see where the tubing is going into the hole. So yes, the surgeon has to drill a hole into your head to get the tube in here. This is the view from the back. This is the shunt valve, and then here's the tubing coming down here, and you can sort of see all the blood vessels in there. So that's what that looks like. But here are what some examples of shunt valves look like. Now I promise they're not that big. They're actually about the size of your fingertip if you feel it under the skin. So this one is a programmable shunt. This is a different programmable shunt, and this is just an example of how those different programmers work. And most of us who are in this field are going to use these programmable shunts. So how does that work? So the purpose of a shunt is to allow just enough spinal fluid, but not too much spinal fluid to flow. So we're actually adjusting the tension on a tiny spring valve. Tiny spring valve. And if we make it harder for the valve to open, it needs a little bit more pressure to open, it won't open as much through the course of the day. If we make it easier to open, it'll open more through the course of the day and drain more. Any of you have a storm door at home? So you know that little thing that you adjust to make it easy to open or hard to open? It's the same idea. You can either make it easy to open or hard to open. And this is a graph that shows with a particular shunt how much pressure is required to cause it to open. So we really are adjusting that. And this particular shunt has a setting where it's so high we call it virtually off, like that. So the goal is to drain enough but not too much, and when we're using a shunt, we're looking for that setting that I call the Goldilocks setting. It's not too high, it's not too low, it's just right for a person. So we're going to talk next about testing that is specific for predicting the response to shunt surgery. What we want to know in advance before we recommend surgery is what is the likelihood that that surgery is going to help a person. And the reason that that's important to contemplate is because every surgery has potential complications. So you want to be sure that the benefit that you're expecting from that surgery outweighs the possible risks associated with that surgery. All right? So the goal of testing is to predict who will improve with a shunt and who will not. And not everybody that I test looks like they're going to improve with a shunt. So those who do will get shunt surgery. Those who are unlikely to benefit should not have shunt surgery. Everybody wants to get better, but everybody wants to make the correct decision. Nobody wants a surgery if the odds of it helping them are tiny. It's very rare for somebody to tell me that. So a shunt, we just talked about it, works by helping to drain spinal fluid. So if you drain spinal fluid on a short-term basis and assess a person's response, you are in a better position to say whether a shunt should be recommended or not. Now, there are two ways to do that, and they are variations on the same theme, which is a lumbar puncture or a spinal tap. So one is to do that in the clinic, and the other is to do that in the hospital by actually inserting a temporary tube into the spinal fluid so you can drain fluid to the outside. Now, if you're going to do that, then you have to measure what it is that should be getting better. And that's the walking and the balance. Walking and the balance is the main symptom of hydrocephalus. It's the thing that most patients and their families are worried about if they can't walk. Remember the Carol Burnett show, that little old man character that Tim Conway used to play? All right, this is not good. And if you're an older couple living together and one of you falls, you may not be able to help each other. So that's what really gets everybody's attention. So we have to assess that before we drain the spinal fluid and after we drain the spinal fluid to make sure that they're getting better. Now, I do that myself in my clinic. That's the way that my clinic is set up. But there are centers who have others do that, like physical therapists. Now, I also ask my patients and their families what they're perceiving, but I don't rely on that alone. And part of it is because all of us naturally want to say, oh, I got better. But we want to distinguish between what we're hoping for and what we actually see. And the truth is, it's not very often that I get somebody who's insisting they're better when we haven't been able to document that ourselves. Now, you're going to ask about what about the thinking and the memory? Do we assess that before and afterwards? And the answer is no, not most centers. And the reason is that it's very difficult to show a substantial improvement in thinking and memory on a short-term basis with testing. And there's two reasons for that. One is that it really does take the brain more time to recover that function. The other is there's a little thing that we call the practice effect. So if I give you a screening test of memory today, and then I give you the very same screening test of thinking and memory tomorrow, how do you think you're going to do on it tomorrow? You're going to do better. That's called the practice effect. So even when we do such testing, we have to use different forms to try to minimize that effect. So what does this walking look like in hydrocephalus? So this is a little technical up here, but I give that to you so you can understand what I'm looking for. So there's lots of this sensory information that's coming in from our eyes, from our inner ears, from our sensation, where is our body. The brain has to take all of that information and execute appropriate reflexes to keep us upright and appropriate patterns so that we can walk normally. And that's impaired in hydrocephalus. This higher brain control of the walking is what's wrong. And what a lot of patients will say, which is true, is I can't make my feet do what I want them to do. I'm trying to get going and I can't get going. Or sometimes I get going and I can't stop, is the other thing that we see. And so they have difficulty initiating gait. They feel like they're stuck to their floor. Sometimes they're stooped, but occasionally they're pushing backwards like this. They try to get up from the chair and they're pushing backwards. Boom, they're back where they started, like that. Slow, shuffling steps, short steps. They go to turn around. They get thrown off balance when they're turning around, because even turning around you need balance. If they go out on uneven surfaces like gravel or a lawn, and somebody reminded me today that you have hazardous fire ants out here that you have to run away from. So you may not be able to run away from the fire ants if you have hydrocephalus. So, but difficulty with uneven terrain. We don't have those in Seattle. It's one of the nice things about being in Seattle. Now, the other thing that happens in clinic, and it doesn't matter whether it's the patient is the husband or the wife, their spouse says, I can't believe he's walking this good for you. That's not what he looks like at home. And that's really characteristic. So one of the sneaky things that I do is I'm watching you both when we're out there doing the walking, but I'm watching you when you're going back to the waiting area and you don't realize that I'm assessing you. And sometimes there's a big difference. So neurologists are sneaky that way. Sometimes we're collecting information about you when you don't even know it. So let's talk about these two tests, spinal tap or spinal catheter. Anybody know what a spinal tap involves? So let's first talk about that. A spinal tap is a procedure that's been done for more than 100 years, actually about 130 years at this point. The first one was described in the late 1880s. And if you go onto Google and you type in spinal tap, you're going to find all sorts of scary stories about spinal taps. If you have your spinal tap done by somebody who knows how to do it right, it's really not a bad procedure. And yes, I have had one. Not as a volunteer, I got sick once, and actually it's the neurology residents who I was training had to do that on me. So what I said to them is, I'm going to get into the right position, you guys just do a good job with the spinal tap. And so they did a very, very good job. But it involves numbing up the skin of the low back. Now the spinal fluid goes all the way down to the back, practically to the tailbone. But the spinal cord ends higher than that. So there's an area in the lower spine where you can put a needle into the spinal fluid and not worry about hurting the spinal cord. Now, there's a lot of positioning and so forth, but you can do that with local anesthesia. It sounds icky, but we slide a needle in there. Once the tip of the needle is in the spinal fluid, if it's in my clinic, we can then fill about 4 test tubes full of that spinal fluid. That's the removal of spinal fluid for the test. Take the needle out, put a little bandage on you, and you're good. So that's the outpatient spinal tap. And if somebody really gets better, and I'm not talking about, well, yeah, it's kind of like a good day. I'm talking about, wait a minute, let me capture this and post this on Facebook. That kind of improvement, where everybody says, wow. Then we can say, yes, you have responded to the spinal fluid drainage, and we're going to recommend a shunt operation. But if you haven't responded, or you're saying, well, maybe a little bit, you probably haven't responded. So if you definitely respond, we can say, yes, there's a very good likelihood that shunt surgery will help you. In this case, we can't necessarily reach a conclusion with a standard spinal tap in the clinic. And that's because there are some people who need more spinal fluid drainage for a longer period of time in order to see that response. So that's where this other protocol comes into play. So spinal catheter, you do have to come into the hospital for about 3 days. And the spinal tap itself is essentially the same spinal tap, but the difference is this. We're passing a thin, flexible tube through the needle into the spinal fluid. We take the needle out and hook that tube to a drainage system, drip, drip, drip. So that allows us to drain more spinal fluid for a longer period of time. It's imitating the effect of a shunt. So when somebody has the same sort of improvement with that, we're going to make the same recommendation that a shunt is very likely to help you. If you don't get better, then the chances of improving, if you said, well, I want a shunt anyway, are only between about 10% and 15%. The spinal tap is the same. Now, there is a very small chance of infection. Anytime a doctor says, I want to put something into you, doesn't matter whether it's a hip or a pacemaker or a shunt or a temporary tube, there's always a small chance of infection. So you want a doctor who knows what that risk of infection is, who will do everything to keep that risk from happening. Now, that risk is about 3%, and that's based on research that I've done as well as others. Now, my paper on this is about 15 years old. If you say to me, when was the last time with my patients that I had an infection, I will tell you it was in 2008. And that's because I am meticulous about avoiding infection. But I never promise my patients a 0% chance, because I've seen it. But my job as a doctor is to keep that risk as minimal as possible. So does this testing help us? It really, really does. If somebody has responded to spinal fluid drainage, then there's up to a 90% chance that they're going to get better with a shunt. So those are pretty good odds, and most people who hear those odds and have experienced the response to the spinal fluid drainage say, yeah, I'd like to keep it that way. A shunt is the only way to keep it that way. But with the spinal catheter, if you haven't responded, if you have what we might call a negative test, then there's only about a 10% chance of getting better. Now, I've had some patients who said, I'm willing to take those odds, and we have a long talk about how that will play out. So the testing isn't perfect, but it really helps us to understand which way do we want to go. It helps us to understand what to look for, what we can anticipate. So you might say, do we ever skip that testing? Is there ever a time when I see somebody and say, yep, let's call up the neurosurgeon and get you the testing? The answer is yes. This is based on an approach that my colleagues in Japan have been describing for a long, long time, and it's for a very, very specific subgroup of patients with hydrocephalus. They have all the right symptoms, their scan looks just the way it ought to look, and it's immediately apparent that they don't have any other causes. And they go directly to shunt surgery for that. And I've known my colleagues for a long, long time, and I will tell you the first time that I ever took that approach was just last fall. And I said to the neurosurgeon, we don't need any testing. And he looked at me and said, are you sure? I said, yes, I trust my colleagues in Japan. I know them, I know their work. And part of my job as a neurologist is to understand, can I replicate what others can do and do that in a way that's not harmful to patients? And in fact, this patient has gotten better, exactly as my friends from Japan would have predicted. So that's the good news. But in the United States and Canada and Europe, my friends from there, this particular approach hasn't caught on a whole lot. So I'm always trying to be sure, am I using all the approaches that I can? Now you might ask, okay, you got me to a neurosurgeon, I got this neurosurgery haircut to have a shunt put in my head. Am I really going to get better from that? And the answer is that yes, all three of these symptoms can improve. I have had patients who couldn't walk, who needed a wheelchair, or could barely stand up holding onto a walker, get to the point where they could walk with just a cane. I've had patients who've had lesser degrees of improvement, but what we're looking for is not that I can say your score got 2 points better, but can I make you better? Can I help you at home? Can you get around? Can you get up off the floor? Can you get out to the store? What we would call a functional improvement. The cognitive function can also improve, and the bladder control can also improve. But how much a person improves depends in part on how much this, that, and the other thing they have. So if your walking gets better and your thinking gets better, but you're still having trouble with the bladder, well, I'm going to get you to see the bladder specialist so that we can understand what else is going on. So let me show you just one study. I'm not going to overwhelm you with the scientific literature here, but it kind of gives you an idea of what can happen. So Petra Klinge is a friend of mine. She was in Germany when this paper was put together. She's now in Rhode Island, and there was a European trial. And so all the patients who came in got a shunt. And they all had the clinical appearance, they had the radiology appearance, they did a bunch of different testing, but let me show you what happened to the outcomes. Now these are two different scores. And so anything above the dark squares is what their score was before, and below that is afterwards. And what you see is almost everybody has moved in this direction. That means improvement. I know it's a little bit hard to understand that, but what you can really see is there's just a few patients who are on this side of the line, which is the unimproved or worse side of the line. Most of them are over here. And that turns out to be about 70% of the patients in that trial who got better. And this is looking at a scale that is a composite of walking and balance, bladder control, and thinking and memory. So they're moving in that right direction. So I've hinted that there can be complications of shunt surgery, and we ought to talk about that for a minute. So there's what we call early and late complications. So the early complications are what might happen for the surgery or the anesthesia itself. Now, you remember I showed that the shunt is a tube that goes into the brain. It's designed to go into the brain without hurting it. Shunts actually get put into babies all the time. Babies can have hydrocephalus. So it's designed not to hurt the brain. Every once in a while it does, but that risk is quite small. Anytime you put something in a person, there's a chance of infection. That can happen. The risk is very small. And because the other end goes down here into the abdomen, there could potentially be injury to the abdominal organs. That's also very uncommon. So those are the early complications. Late complications are what might happen 6, 8, 12 months later, longer than that. And the first is that the shunt's just a little drainage system. Any of you have gutters at home? Your gutters ever get clogged? A shunt can get clogged. If that happens, the old symptoms come back. And some of my research has shown that if you find that and you fix it, there's a 75% chance that the person will get better again. So one of the reasons that people need to be seen after they have a shunt is to make sure they get as well as we expect them to and to keep them that way. Now, the other side of that is, remember, we're using these adjustable shunts, and the job is to drain enough but not too much. Well, sometimes we do drain too much, and you can get what's called a subdural fluid collection or subdural bleeding from that. And when we can, simply what we do is change the shunt setting to slow down the rate of drainage to try to correct that. In rare circumstances, somebody actually might need surgery because of the bleeding. And then the last is there can even be delayed infections. So this is from that European trial. This is a list of the of complications, but there were only a couple that required surgery. Most of these complications that they're showing here could be fixed without surgery. So in my mind, it's not a serious complication if I can treat you just by adjusting the setting of the shunt. But if I have to send you to a neurosurgeon, we would call that a major complication. So, okay, now I've got a shunt. What should happen next? I'm a big proponent of physical therapy. A shunt is going to allow your brain to control your walking and your balance and your thinking and memory better, but you have to relearn a lot of these tasks. Physical therapy can accelerate that. And my colleagues in Sweden are actually publishing a paper to show just how much difference that makes. And I think that you need regular follow-up with a neurologist or a neurosurgeon. It's not just have a shunt and good luck with that, but come back and let's be sure you got as well as we wanted you to, and we're not having complications. So when I see patients in clinic, we're talking to each other, deciding are they better or not, and do we need to adjust the shunt. So I'm going to tell you about one of my patients, and you can see this is from a long time ago, and you're going to see his picture in a second. He gave me permission to show this. So he was 78 when he came to see me, and he had trouble with his walking and balance and thinking and memory and his bladder, and he was one of these guys. And he had an MRI scan that could either be hydrocephalus or this vascular disease. So he had started to use a cane in 1999. Somebody had actually done a spinal tap in the clinic, nothing. By 2002, before he saw me, now he's using a walker. In September of 2002, he's stuttering in tight places. And when I first talked to him about testing for hydrocephalus, he said, it's not that bad. And the second time I saw him, he said, it's still not that bad. But the third time, when he was finally in with the rolling walker, he said, okay, let's do it. So this is a Gait scoring system. So look just at the green bar, and you can sort of see what's happening to him over time. He's getting worse and worse and worse. And then we had him into the hospital. He'd already had the one spinal tap, so we brought him into the hospital. He clearly responded. Then he got the shunt surgery. And look what happened to his Gait score here. Boing! He's back up almost into the normal range. And he was pretty happy about it. By the way, these are called snowshoes. I know you don't have those down here. They're really good for fire ants, I think. So here's our summary, and we're right on time here. There are some patients who are originally diagnosed with Alzheimer's disease or Parkinson's disease who turn out to have hydrocephalus. So that really is the case. We get that story. The first step in diagnosis is the careful assessment of all of these details we've been talking about, the exam and the scans, and excluding other causes of their symptoms. Testing to predict, is this somebody who's got a good chance of responding to a shunt, and then getting shunt surgery, and then if we do that, the chances of responding to surgery are pretty high. Now, I always talk to patients and families about what I call false pessimism and false optimism. And there are some patients who've seen doctors who said, no such thing as NPH. Or they say, oh my God, your shunt's going to explode if they put a shunt, your head's going to explode if they put a shunt in you. They're afraid the complications are bad. And the truth is, if you look at what was happening in the late 1960s and 1970s when this was first discovered, yeah, we had a lot of problems, but our technology was not that good back then. And that's just not true. There really is a thing called hydrocephalus, and if you pick somebody for a shunt correctly and you know how to use a shunt, shunts are safe. So my cautious hope for you is not that if you come to see me or come to a center for normal pressure hydrocephalus, that automatically means you have normal pressure hydrocephalus, but they're going to do the testing to figure out, do you or don't you? And it is the case that not everybody that I see turns out to have normal pressure hydrocephalus, but almost everybody I see is grateful that we took the time to look. Because nobody wants to miss the opportunity to get better if it's there. So they're grateful that we took the time to look. So this is my cautious hope for you. If patients who do respond to shunt surgery are often significantly better, they walk better, they fall less, they're more independent, they typically have better bladder control. So if you know someone who might have NPH, don't be afraid to talk to your doctor and say, I'd like to get to a center where that can be evaluated. I think I know where one of them is, right here in San Antonio. So that gives us some time for questions.